Survival's important, but it makes no difference if the patient's quality of life is dwindling in that period. Probably the roughest thing is to have a patient live longer, but live more poorly because of either toxicity or because the after effects of the cancer remain. A remarkable observation from the Keynote 189 trial was that quality of life was preserved or stabilized for a much longer period on the combination arm compared to the control group. I believe the median was not reached versus about 7 or 8 months for the control group. And amongst those who actually had an improvement in quality of life, at about 20 to 24 weeks, a borderline significant increase was seen again in the pembro arm. So not only are we maintaining quality of life, we actually see at some point during the course of treatment a relative advantage for pembrolizumab, and that really is distinct from many other trials that have looked at quality of life in this setting. Many of our patients fear that no matter what we do, their quality of life is going to be compromised. It's really quite the opposite. Cancer itself, particularly advanced non-small cell, will compromise a patient's quality of life. If we can prevent deterioration in their typical symptoms and cough or chest pain or shortness of breath, their quality of life will improve. And many of my patients are quite surprised by how much better they feel while they're on treatment. And if we do a good job controlling toxicity, the advantage remains. We're not compromising that improvement in disease-related symptoms with treatment-related symptoms.
A quality of life analysis was performed for Keynote 189 looking at time to deterioration of symptoms, and despite the greater incidence of grade 3 to 5 adverse events, quality of life was maintained in the investigational arm for these patients, demonstrating that there is overall benefit beyond response rate, progression-free survival, and overall survival.
Quality of life for patients with any advanced disease is of paramount significance. I mean, patients don't want to be spending their time in a hospital setting or in and out of a clinic for evaluation just because they're getting treatment. Now, I think we're fortunate that we practice in an era where we have not only fairly efficacious drugs, but also well-tolerated drugs. So I think it's always important to keep in mind that grade 1, 2 toxicities that we normally don't concentrate on, when they become chronic and in fact have an impact on patients' quality of life. When I teach my fellows, I always say, yes, 2 or 3 bouts of diarrhea a day might not elevate something to requiring intervention, but you can imagine if you have 2 or 3 bouts of diarrhea that's unpredictable throughout the day, you don't want to leave your house. So that does impact quality of life for sure. With that in mind, the chemo combinations, at least based on the units that we measure in terms of dyspnea or other factors, seem to suggest that the combination with pembrolizumab plus chemotherapy is actually better for symptom relief like that than the combination of chemotherapy alone. So here we're, again, in a fortunate setting where we can sit across from a patient and say, not only do I have a combination that's very active and can help you live longer, but also I think we can manage your quality of life to be fairly decent because we have data that actually suggested that certain these symptoms actually improved more with the addition of immunotherapy as opposed to chemotherapy alone. So I think absolutely patients want to have a good quality of life. They want to be able to enjoy the time that they have with their families. They want to be active, productive. A lot of my patients still like to work, so combinations like this provide us with an opportunity to keep our patients doing what they want to do.